It is remarkable that, for all the sophistication of modern obstetric practice, uncertainty should persist concerning the management of as fundamental a problem as breech presentation, particularly with respect to external cephalic version, ECV. This program will focus on information available for guiding clinical decisions and practical aspects of the procedure.
Part of this checking for the contraindications involves doing an ultrasound scan, checking particularly to exclude conditions such as placenta previa, which would be an absolute contraindication to external version. Then we need to confirm that the fetus is in good condition by running a non-stress test, a cardiotocograph tracing, and confirming that we have a reactive pattern. During the procedure, we auscultate about every 2 minutes to check that there is no slowing of the fetal heart. And if slowing of the fetal heart is heard, then we stop the procedure, wait, allow the mother to relax before trying again. And we also try to limit the duration of pressure on the uterus to 5 minutes at any given time. And if we're unsuccessful within 5 minutes, then we stop, leave the mother to rest for a few minutes, check the fetal heart, and then try again.
We will now view 2 external cephalic version procedures.
This is Ruth's first baby, and she's 39 weeks pregnant and in very early labor. And the problem which presents is that she has a persistent breech presentation. It's a frank breech presentation, the baby's back being on her right. We've discussed the options and decided together with her to attempt external version to improve her chances of a normal delivery and avoiding cesarean section. We've done an ultrasound to confirm the position of the baby and that there's no cord around the baby's neck and that there's no placenta previa. We're now running a non-stress test to ensure that the baby is in good condition prior to attempting external version, and this has shown a reactive pattern. We've positioned Ruth on a narrow examination couch and with her back supported with a pillow against the wall so that she's tilted at about 30 to 45 degrees to her right. And the first step is going to be to attempt to relax the uterus with hexaprenolone. So Ruth, I'm just going to give this injection through the needle that we put in before. And when the injection is going in, you'll feel that your heart may beat a little bit faster. That's normal with this injection. Hey, so you mustn't worry about that. We have hexaprenolone 10 micrograms drawn up, and we'll give somewhere between 5 and 10 micrograms, very slowly, depending on the response. If her pulse rate goes above 120, then we'll stop the injection. Now the main thing, Ruth, is to keep your muscles very, very soft. Just relax as well as you can. Hey, just keep relaxed. Don't move yourself. Just keep very well relaxed. We're going to be manipulating mainly the breech rather than the head, and so we will try first for a backward somersault. The baby's back is on the mother's right, and the most important aspect is to try to get the breech out of the pelvis. And to do this, we need to get 8 fingers of both hands quite deeply in, above the symphysis pubis, and then very gently lift the breech out of the pelvis. That's very good, Ruth. You just relax all your muscles. Keep well relaxed. That's very good. Once the breech is out of the pelvis, we hold it firmly with the left hand and sit down, and then steadily and firmly push the breech away from the pelvis and towards the mother's left side. Okay. Just relax, Ruth. Keep your muscles very soft. That's good. As the breech moves up, we can gently see whether the head will come down. Sometimes a little bit of backwards and forwards movement between the two hands. Okay. It's not coming down past this position.
To attempt a forward somersault, the patient is turned head to toe on the couch so that the operator is on her left side, the baby's back being on her right side nearest the wall.
We'll try once more to see if it will turn in the opposite direction. If you just keep yourself nicely relaxed the way you have been doing, that's very good. Relax all your muscles, Ruth. Keep very, very soft.
For a forward somersault, more pressure can be applied to the head with the right hand to maintain flexion of the baby. That's very good. So now the baby's turned. The head's down here. Baby's bottom's up here. Can you feel that it feels different? It feels different now, hey? And the baby's heartbeat is fine. So there you can see on the ultrasound scan the baby's head down at the bottom. The most important part of the external version is to get the breech out of the pelvis. So I'm going to press down, Lorraine, try and relax all your muscles. Okay. So using the 8 fingers of both hands, we scoop the breech up out of the pelvis. Sorry, Lorraine. Once it's well out of the pelvis, we steady it with the one hand, and then steadily press the breech up away from the pelvis. While guiding the head downwards with the other hand. The fetal heart rate may be non-reactive for a while after external cephalic version and usually becomes reactive in 30 minutes. Ultrasound may be used to confirm the cephalic presentation at the end of the procedure. The woman should not go home until fetal well-being has been confirmed. Should ECV be attempted during labor?
Theoretically, labor is an ideal time to undertake external cephalic version. Firstly, one has waited as long as possible for spontaneous version to take place. Secondly, if the version is successful, one is able to then monitor the baby's condition continually until delivery. And thirdly, if one is dealing with a woman in whom, for one or other reason, vaginal breech delivery is considered not advisable, then the external version attempt can actually be made in theatre, and if it's unsuccessful, one can go straight on to caesarean section at that time. And in these ways, one can absolutely minimize the risks of the procedure to the baby. The only disadvantage of waiting till the onset of labor before attempting external cephalic version is that the membranes may rupture prior to one's attempt, and it has been shown that once membranes have ruptured, attempts at external cephalic version are uniformly unsuccessful. Nevertheless, if one is faced with a situation of a woman in labor with a breech presentation where there are no contraindications to external cephalic version, where the membranes are still intact, one series of such cases has shown that the success rate is very similar to the success rate achieved with external cephalic version prior to the onset of labor. Obviously in labor one will virtually always use a tocolytic to stop contractions for the duration of the procedure. So external cephalic version during labor is something which should be kept in mind as a very useful procedure when the need for it arises.
Is there a use for ECV in primary care settings?
Up until now, we've discussed external cephalic version in a situation where one has access to facilities such as ultrasound, cardiotocography. What about women in areas where we don't have these modern facilities? There one has to weigh up the risks and benefits of the procedure in that environment. And it seems likely that with careful clinical assessment of the situation, the risks of external cephalic version without being able to check with ultrasound and with cardiotocography, but simply doing a clinical evaluation and asking the mother about fetal movements as an indication of fetal well-being, the risks of the procedure might be slightly increased, but on the other hand, the risks of persistent breech presentation in a situation where there are not good medical facilities is probably increased even more. And it would seem that the balance of benefit would remain on the side of external cephalic version in that situation.